We have with us Dr. Praveen Kumar, who's a phaco-refractive surgeon from Shivakasi, and he has a very impressive video to show us and make us ponder on why it happened. On to you, Praveen. Praveen?
No, we can't hear you, Praveen, and your
Unmute.
screen.
Please unmute.
No, yeah, now.
You have to share your screen. Praveen, you're sharing your video?
Yes, ma'am.
Okay.
Yes, ma'am.
Yeah. Take your time.
Is it visible, ma'am?
Yeah.
Good evening, everyone. First of all, I would like to thank Chitra ma'am and the ARC for giving this opportunity to speak in this webinar. So actually, I don't know where there's any learning pearl in this video. I'm just showing you a mature cataract with moderate dilatation, which I managed recently. So this was a 65-year-old lady who presented with phacomorphic glaucoma with pressures above 50 and a hazy cornea. So it took a couple of days to bring down the pressure before taking her up for surgery. As the nucleus appeared very swollen and intumescent, even on the day of surgery, I gave her 300 ml of mannitol to keep the pressures low. As the cataract appeared grade 2 mature, I thought I can manage even if the pupil was mid-dilated. And after staining the capsule with blue Rex, I started with my preferred mini can opener technique, where I make multiple nicks and let the milky cortex ooze out slowly. As there are multiple nicks, the intralenticular pressure is kind of diluted in all directions. Moreover, I keep injecting visco beyond the nicks so that it keeps the capsule flat, and it's very easy to hold to one of the flaps and complete the rexes. Then I decided to go in with the phaco and try to do a direct chop. But what happened, I don't know whether because of the hazy cornea and the shrinking pupil, and I didn't have the confidence to go well deep into to bury the probe. So I was not able to complete the chop as desired. So I didn't want to take a chance. I came out and I put iris hooks. I normally use 5 hooks, and then made a small nick on the rexis margin. And I did. I wanted to enlarge the rexis, and I enlarged the rexis margin. So now I had better visibility. So I was able to bury deep, and I was able to make the first chop. So again did my second chop, and I removed one piece from one half of the cataract. So after this I tried to again rotate the nucleus. It wouldn't rotate freely. So this time I tried to remove a wedge from the opposite end. So when I tried to remove from the opposite end, and I was again able to remove one piece from the other half. So after that, I again tried to rotate the nucleus. It was kind of very difficult to rotate. Then I started noticing that the nucleus was tilting subincisionally, and it had kind of come into the chamber. So I tried to inject visco, and I thought of putting a CTR. I normally support the CTR with a dialer so that it doesn't keep lifting away into the chamber. And the last part, I prefer to use the double dialer technique, where I engage the CTR with one of the dialers, and then leave it inside the bag. So I was thinking whether if it was stable, I'll continue this way, or else I thought of repositioning the iris hooks to the bag. So then I slowly dialed and found that the bag was kind of stable. So after that, the procedure was quite simple. I was able to complete the pieces in a like a manner which was anticipated. After that, things went fine. So just for the sake of time, I just fast forwarded it. So after that, once the bag was stable, there was good followability of the pieces, and all the pieces started coming to the phaco probe, and I was able to complete it quite comfortably. So after completing this thing, I used because as there are multiple openings, I went along with a coaxial IA and completed the IA, and then I injected a single piece hydrophilic IOL, and then removed the hooks with the visco in the chamber. Following which, just for completion's sake, I was just trying to remove the tags, whichever tags of cortex which were stuck behind the CTR. So once I was able to remove as much as possible, I hydrated all the wounds, and the chamber was quite well formed, and the patient did fine in the post-operative period. Thank you.
Thank you very much, Praveen. That was a wonderful video. Can you stop sharing your screen?
Yes, ma'am.
So what could have been the possible cause of dialysis? Could it have been that you started attempting phaco in a small pupil and by mistake caught the rhexis margin? And the
Not
other
sure,
thing
because
is learning tip I wanted to add before I want all of you all to discuss is when you have already created a rhexis and you're placing the iris hook, I think it makes sense to inject a little viscoelastic under the iris so that you place your iris hook appropriately so that you don't catch the rhexis margin. But other very important thing which you could have done is you could have taken the iris hook and positioned it to stabilize the capsular bag itself when you found as dialysis and finished your case and then place your CTR right in the end. These were my thoughts about your case. Yes, you were answering?
No, actually, I was not maneuvering too much. As soon as I tried to chop, the pupil started shrinking and the cornea was kind of hazy. So, not that I tried to chop too many times for it to cause the dialysis. The first attempt itself, I came out and I thought I will, enlarge the pupil before attempting further. So probably it was the zonules are weak already. I don't know when it happened.
Anybody wants to add? Dr. Mahipal?
No, I think he managed the case well. In hypermature cataracts, always the zonules tend to be they're hypermature, so you can have that. And specifically, once the fluid is coming and your chop directions or something, the only thing is that you have to realize it fast, which he did. And both of them are complementary, I would say, putting the CTR as also the capsular hooks. And he managed it well. Great job done.
Yeah, true.
One point I had, very well done surgery, Dr. Praveen. One thing I wanted to ask you, because it was already a complicated cataract with, in the sense it was phacomorphic. So because there was a mid-dilated pupil, probably if we use a pupillary expander right in the beginning so that, so that you would avoid having these complications, because you ended up having a smaller rhexis, then people came down even further, and maybe using adrenaline or phenocaine plus, and maybe at that time that would not have worked. And then putting in retractors in the middle of the surgery,
I didn't expect it to become that small.
in the beginning.
Yeah, sure. I didn't expect it to suddenly shrink. I thought it will stay at that 5 millimeter.
Yeah, so maybe I think take-home message is, if whenever you're in doubt or if it's not a routine cataract and if there's some kind of other risk factor, then maybe it is better to use a pupillary expander and good visualization.
Sure.
One of the things is that I don't know, some people are not routinely using a non-steroidal anti-inflammatory drop at the time of dilatation or before that to keep the pupil, the intraoperative meiosis tends to come down if you're using non-steroidal anti-inflammatory drops as an adjunct to pupillary dilatation drops.
Yes.
That is
true.
I completely agree, Mahipal, sir. It makes a huge difference.
Yeah,
for all cases of flags, I mean, you routinely give it because even otherwise you should do it.
Yeah.
Namrata, that's because you're using a Lensex.
I think, From Lensex to Catalyst, that's what I was going to say, because both Gaurav and myself have experienced the amount of pupillary constriction that happens with the Lensex because the dock is much harder, is much more than in the Catalyst.
So we are well on time. So we shall now go on. Any more questions to ask? Shall we go on to our last speaker?
Yes, Chitra.